Hi, I'm Dr. Joe Rogers, President and CEO of the Texas Heart Institute, and I'm joined here in the studio today by an old friend, Sanjiv Narayan, who's just given grand rounds at the Texas Heart Institute. Dr. Narayan is a professor of medicine in cardiology at Stanford University and really has a great expertise in the management of all kinds of cardiac arrhythmias. But I wanted to sort of take some of the things that you discussed today, and I'd like you to amplify them a little bit. And I want to just focus us in on atrial arrhythmias for the purposes of our discussion. And I wanted to focus around really four main themes. And you know, I have a great respect for you and all of the work that you've done since we originally became friends decades ago.
Yes.
You've had a remarkable career. But I think you're such an interesting forward thinker about all things cardiology, but particularly in the space of electrophysiology. And so I'd like to explore your thoughts about how we will be preventing atrial fibrillation in the future, how we'll be using different kinds of tools and technologies to detect it early, and the kinds of approaches that we might anticipate in terms of new treatment modalities. So let's start with prevention. What do you think we'll be doing 5 and 10 years from now to actually prevent people from getting atrial fibrillation?
Yeah. Well, Joe, first of all, I really wanted to thank you for the invitation. It's really been a pleasure to be here at Texas Heart. So impressed by the clinical enterprise. Frankly, the training of the fellows, spectacular. Really enjoyed meeting them and interacting this morning, and then seeing the breadth of the translational research. Absolutely outstanding. So congratulations to the whole team on that. So prevention is such a key area. AF is a monumental and growing public health menace. And I think the new guidelines embodied this. Basics are always fundamental. So weight loss, management of other modifiable risk factors, blood pressure control, things that therefore might reduce LVH at a mechanistic level. All of those things are important. But it's not just that, because if you look at atrial fibrillation, we've seen patients who are athletes and incredibly healthy with AFib. We've seen people who are actually, frankly, should have AFib but don't. So I think we need to somehow understand in which people each of these factors are modifiable, and are there other things we don't identify? The obvious ones there that we're scratching the surface would be alcohol. Mm-hmm. Sometimes it's really important, but not always. Why? Is that due to some level of, alcohol dehydrogenase, subclinical deficiency, and who knows? Sleep. We all need more of that. So things like that, I think, are going to be key. How tricky? I mean, the ideal thing would be massive data exploration by a company with the resources like Google. Better would be people like us putting together a consortia that are open, developing algorithms that are not proprietary. But that's the way. But then you'd have to label those data. These people do well, these people do poorly, these people are stable. But that might be a way forward.
I want you to expand a little bit on some of your talk today, where you focused in on using new tools as strategies for prediction. And there's this explosion of
Absolutely.
Machine learning. There's an explosion of wearables. In 5 or 10 years, how will we be predicting who's likely to get atrial fibrillation once we have a sense about people who are more at risk?
So I think that there's a lot of promise, and I think that we always get surprised by curveballs like ChatGPT. But this is a difficult question. Okay, so AI is great at easy questions because you can train a model to separate, we discussed this one, a dog from a cat. I mean, but then again, AI is also pretty good at facial recognition, not perfect. My son can unlock my phone, which is a problem, taken off all the banking apps. So I think that the better your output label And the more expansive your data with good output labels, the better it would be. Predicting AF is hard because a lot of people we'd say don't have AF might have some in sleep. So that's why I'm a little cautious about that. If you were to say people with known AFib, so let's make it narrower, people with known AFib that's mild, will and won't progress, I think we could make progress there because you already know they're in the system. You can monitor them. We can slap on some wearable and then you can look at patterns. And over 5 to 10 years, I think we could get there. And that is a key because, as you know, the recent paper, Andrade NEJM 23, showed that if you can treat certain people early, you can prevent progression, you can change the natural history, and that keeping those people in sinus also reduces mortality. So massive implications of that.
Many of the people that watch this segment after grand rounds take what we discuss and go back to their office in the afternoon or on Monday morning, and they'll see patients who present with palpitations, so common in all of our practices. What are you doing now in your own practice in that patient population to try to distinguish rhythms that require some sort of additional testing or intervention from those that are much more benign?
Yeah, that is such a timely question. I think what we should be doing is evaluating the patient, like as clinicians, are they young individuals who are stressed because of exams? And I wouldn't necessarily work up those individuals immediately. But in people in the middle group, which we're always dealing with, I would probably go early to an ambulatory ECG. If you were to pick up, so there are many brands, if you were to pick up AFib, recent study, the Artesia trial recently showed that, number one, people with previously subclinical AFib are at increased risk of stroke. Now, the stroke risk is far lower than your standard clinical AF patient, but subclinical AF does have a risk, and therefore that opens them up to potentially really important treatment, anticoagulants and so on, maintaining sinus rhythm potentially. Then what I'd like to be able to do, but not yet really available, is just do a straight 12-lead ECG, apply AI to the ECG, and get an accurate assessment without all the paraphernalia of putting in a patch. And I think that might happen. I mean, it's been mixed. I showed data, phenomenal data, Noseworthy et al. And others from Mayo, showing that the just 10-second ECG in sinus, AI has a 0.87 AUC for future. It's remarkable. I mean, the question is, does the database of Mayo extrapolate to the whole world? And recent study challenged that a bit from Jag Singh's group we were chatting, from MGH, that it wasn't as informative. It still worked. It wasn't quite as good. But I think that there's enough evidence that could be really refined. And I think that would be such an obvious no-brainer. Now you translate that to just an ECG from your watch, and you're really off to the races.
Yeah. I think that the potential power of machine learning to help us see things in electrocardiograms that we've never observed before, because they're so subtle that our eyes just don't see them. But when you apply this intense learning to millions and millions of ECGs, I think that there is this really exciting potential for early prediction, if you will, of AFib.
Yeah. Every time I think the ECG's reached its limit, as you know, we did ECG work together at WashU in the old days. So it's every time I think it's reached its limit, there's another boundary broken down, predicting your age. And if you look older than your stated age, you've got a disease process. Incredible. Yeah. So it's amazing.
And then what are you thinking about the future of therapies for AFib? It seems my interpretation of the literature is that more and more we're thinking about what I would declare more definitive therapies like ablative therapies for AFib. Do you think that there are drugs in the development pipeline that are likely to have a major impact on the outcomes of AFib, and how do those sort of compare to some of the newer approaches to ablation?
It's a really good question. I think early rhythm control is key. We don't want to let this thing run rampant with rate control and progress. We just don't want that. And of course, it's harder to treat progressed AF. So in terms of drugs, frankly, I think SGLT2 inhibitors will be perhaps my number one bet. They're showing so much promise. You could reduce the obesity-related phenotype. So, and then, of course, there are probably pleiotropic effects we haven't yet unraveled. So I think that would be high on the list. Antiarrhythmics have hit a bit of a brick wall, and I think that there's probably scope for that, but we need for that better clinical trials to inform translational studies to inform drug discovery. But again, drugs get repurposed, and I think that's possible. The ablation field, of course, dear to my heart, I think is very fertile. I did and still strongly believe that for AF, the solution beyond PVI has got to be mapping. I think that stronger ablation tools are great. They've definitely improved tools like PFA, have definitely improved efficiency and safety, and we all want that. I think that in addition, better mapping, and I'm not sure what form that takes, maybe it's phenotyping and mapping, I think is critical. And many people, including we, are working on that.
The other theme that I want to just close with was something that really resonated with me, and you were talking a bit about stroke risk and really beginning to personalize therapy. And it strikes me that we have these large patient cohorts who have atrial fibrillation, and of all different varieties, some paroxysmal, some permanent, some chronic, and yet all of those people are treated with the same anticoagulant regimen. And what are you thinking in terms of really beginning to personalize an anticoagulant strategy so that we're targeting, it's not a benign treatment. So how are we going to personalize that even more going forward?
Yeah, that's an interesting question. I think that going from the earliest stage to the latest stage. So I think for the early stage, Rod Passman at Northwestern has a phenomenal ongoing trial, multi-center, we're part of it, to REACT, where based on the detection of AF, anticoagulation is prescribed for short periods of time only. The obvious idea being when you're not in AF, your risk is low. It's not zero ever, but it's lower. So I think that would be very nice for personalization. Then in the middle group, which anticoagulant, as we know, and you were part of the design planning for things like Rocket, that there's a very different profile for the direct oral anticoagulants. And so there could be a role in the future for measuring plasma levels to determine efficacy and tailoring for those individuals. There's not a huge amount of enthusiasm to do that. People want to make this a one-size-fits-all. But I think that could be one way of personalizing, particularly the extremes. Very, very thin, the other end of the spectrum, obviously renal dysfunction. And then perhaps at the more advanced stages, whether you do something, some interventional treatment, like left atrial appendage isolation or exclusion. And those therapies are increasingly used. It's a bit scary to some patients, instead of a pill, I've got to go through, have a transeptal. But I think overall, as more and more data comes out, it becomes more commonplace. I think there will be patients where it's just better than the ongoing bleeding risk of OACs.
It has been so much fun to reconnect after decades, probably, since I've seen you the last time. So much fun to see the great work that you've done. Thank you so much for taking the day and coming to the Texas Heart Institute.
You're very kind. It's really been a pleasure. Phenomenal.
Thanks very much, Sanjiv.
Thank you.